Yeah, can't thank you enough, Santosh, for giving this opportunity. Uh, it's such a privilege to share my work on this platform. Uh, the technique that I'm going to describe today uh, was intended for our residents or junior doctors who are posted in the periphery. So they are generally asked for cataract surgeries, and if they faced any problems intraoperatively, placing the lens or loss of a bag, then they could use it. So we simplified it to suit their needs and encouraged them to use a rigid intraocular lens with a little bit of modification from the previous techniques that you had. And this technique is called a bent haptic technique. This particular technique won the runners-up award last year for best surgical procedure or innovation. So this study was a prospective study on 43 eyes. We had prior ethical approval, and we did include children in this particular study, and the mean age of the subjects was close to 50 years. So this is how the surgery goes. Bending the rules to make scleral fixation cost-effective. No better way than using the instruments commonly used in small incision cataract surgery. What could be required in addition is a reusable trocar, MPR blade, tissue marker, and lens folding forceps. The surgery begins with a peritomy. The relaxing cut is made at 10 o'clock, and the peritomy is extended clockwise up to 4 o'clock and anti-clockwise up to 8. Less the cutlery, the better. At 1.5 mm from limbus, with the help of a 23 gauge vitrectomy trocar, a partial thickness scleral pocket is made. A second pocket is constructed diagonally opposite to it. And the entry side is stained with ink. One may use the existing corneal scleral tunnel, but if it is on a previously made tunnel, care should be taken to avoid a premature entry. After securing an anterior chamber maintained, the sclerotomy is made right at the entrance of the scleral pocket, and the patency is established with a closed blades of lens folding forceps. Chamber is entered. 26 case needle is bent at 45 degrees, and a silicone sleeve is threaded onto it to receive the lens haptic. The leading haptic is engaged into the lumen of
Video not running.
Not moving properly.
There's some issues, Santosh?
Yeah, video is not moving properly. Now it is okay. Carry on.
And remains anchored to the screen. To demonstrate the bending mechanism, we try to force it into a pocket within a silicon bottle element. As it goes in, bends the tip. To facilitate bending, the haptic is held at a distance from the tip, preferably a millimeter from the tip. In the process of pocketing, the tip gets bent. If we look at the results, the vision improvement was significant at 6 weeks, and the spectacle correction that was required was very, very minimal. So the lens tilt and the centration were independently evaluated, and the centration and the tilt, which was noted on ultrasound biomicroscopy, was satisfactory. However, we had few of the complications which were transient in nature, like a choroidal detachment. It was not present at week 6, although it was seen in early post-operative period. But the most common complication of this particular technique was vitreous hemorrhage, which resolved on its own by 2 weeks. And there was only a single case at 6 weeks that resolved. Cystoid macular edema and subconjunctival haptic exposure did occur, and it was in just 2 of the patients. We had an interesting observation in this particular case series. We found few of the deposits, pigmentary deposits or cellular deposits on the intraocular lens surface, which appeared at 2 weeks follow-up, but it was not progressive. It remained constant till the last follow-up of these patients. And it was seen mostly in those eyes which had endophthalmitis previously or had trauma or a scleral tear repair previously. Possibly the inflammation of the previous surgery had given rise to a reactivation or a worsening of the inflammatory